Good morning, everyone. I hope you're staying healthy and safe. This is the fourth lecture of the female genital tract pathology. Today, we will be discussing some ovarian diseases. These include follicle and luteal cysts, polycystic ovaries, and some common ovarian neoplasms. The follicle and luteal cysts are common, and some believe that they are physiologic and should not be considered as diseases. They originate from unruptured Graafian follicles, or in follicles that have ruptured but immediately sealed. This will allow fluid to accumulate within the cyst, and these cysts may enlarge and become palpable, and they can produce pelvic pain, especially when they become 4 or 5 centimeters or more. Small cysts are lined by granulosa cells or luteal cells, but as fluid accumulates, pressure may cause atrophy of these cells. And a lot of times, when we receive ovarian cysts in the pathology lab, we look under the microscope and there are no discernible lining. This is probably due to the pressure exerted by the fluid within the cyst. Sometimes these cysts rupture, resulting in intraperitoneal hemorrhage and acute abdominal pain. Another possible complication is torsion, in which the cyst revolves around its pedicle, and this also results in severe pain. The most important differential diagnosis resulting from, or in a picture like this with severe abdominal pain in the lower part of the abdomen, is ectopic pregnancy, ovarian cysts, and also acute appendicitis. Polycystic ovaries are characterized by large ovaries, which is at least twice the normal size, gray-white cortex that is studded with subcortical cysts. Clinically, these patients present with oligomenorrhea, hirsutism, infertility, and sometimes obesity, and may appear in girls after menarche. Menarche is the term used for the first menstrual period. The underlying pathophysiology of polycystic ovaries is excessive production of estrogen and androgens by these cysts. Histologically, the ovary shows thick outer tunica with hypertrophic and hyperplastic luteinized theca interna, with the absence of corpora lutea. Corpora lutea are structures that result from ovulation. Since there's no ovulation in polycystic ovaries, you can imagine that corpora lutea are not present. The principal biochemical abnormality is excessive production of androgen, high concentration of luteinizing hormone, and low concentration of follicular stimulating hormone. Treatment is hormonal or surgical. Tumors of the ovary are the fifth most common cancer in women and the fifth most common cause of death, cancer-related deaths also in women. Now remember, there are 3 cell types that make up the normal ovary: the multipotential surface epithelium, the totipotential germ cells, and the multipotential 6-cord stromal cells. Each of these 3 cell types will give rise to a variety of tumors. By far, the most common of them is the surface epithelium, tumors whether benign or malignant. There are several risk factors for epithelial ovarian cancers. 2 of the most important of these risk factors is nulliparity and family history. Nulliparity, again, similar to the endometrium, results in unopposed estrogen, which for some reason also causes ovarian tumors. On the other hand, prolonged use of oral contraceptives reduces the risk of ovarian cancers. The vast majority of cases are not hereditary, they are sporadic. However, when they are hereditary, the majority of them seem to be caused by mutations in BRCA1 and BRCA2. As a reminder, in the breast, BRCA1 causes triple negative cancer, while BRCA2 causes low-grade ER-positive HER2-negative ductal carcinoma. Once again, these are the 3 major subtypes of primary ovarian tumors, epithelial, germ cell, and six stromal tumor, and of course, always we have to rule out metastasis to the ovaries. Common sources of metastasis are the breast and the stomach. As we mentioned, the vast majority of ovarian tumors are epithelial in origin, and these can be divided to some common um, classes such as serous tumors, mucinous tumors, endometrioid tumors, clear cell tumors, and Brenner tumors. Germ cell tumors include teratoma, dysgerminoma, endodermal sinus tumor, which is the other name for yolk sac tumors, and choriocarcinoma. Six-cord stromal tumors include fibroma, granulosa theca tumors, and Sertoli Leydig cell tumors. You probably remember that Sertoli Leydig cells are commonly present in the testis, not in the ovary. However, some rare tumors of the ovary can have Sertoli Leydig cell differentiation. The surface epithelial tumors are derived from the coelomic mesothelium that covers the surface of the ovary. With repeated ovulation and scarring, the surface epithelium is pulled into the cortex, forming small epithelial cysts. All epithelial tumors can be divided into three major categories: benign, malignant, and borderline. The benign tumors can be cystic, and they are called cystadenomas. And cystadenomas sometimes can have a strong or a prominent stromal component and fibrosis. In that instance, we call it cystadenofibroma. The malignant disorders also could be cystic. In that case, we call it cystadenocarcinoma, or solid. In that case, we call it just carcinoma. The first subtype of epithelial tumors is serous tumors. As you probably remember, serous tumors were mentioned in the endometrium, and we said that they appear in elderly women with a background of atrophy. In the ovary, they are the most common ovarian tumors, and most of them are malignant actually. 60% of the serous tumor are actually malignant. Benign lesions are encountered between the ages of 30 and 40, while malignant disorders are encountered between the ages of 45 and 65. They can be small or large, they can be cystic or papillary. All in all, the prognosis of individuals with serous carcinoma is very bad. And similar to the endometrial ovarian carcinoma, they are diffusely positive for p53. Mucinous tumors are different from the serous tumors in the lining of the cysts and the tumor itself. The mucinous tumors are lined by columnar mucus-secreting cells. Additionally, the vast majority of ovarian mucinous tumors are actually benign, in sharp contrast with the serous tumors, which are mostly malignant. The prognosis of mucinous tumors is better than the serous ones, but again, this stage is the most important diagnostic feature. You probably heard of mucinous tumors whenever you hear in the news someone who has excised a large ovarian mass reaching up to 50 centimeters. Likely, this is a mucinous benign tumor. The third subtype is endometrioid tumors. These could be solid or cystic, but sometimes they develop as a protruding mass and can have sometimes cyst filled with chocolate-colored fluid, similar to endometriosis when it affects the ovaries. The lining epithelium is tubular glands similar to those of the normal endometrium. They are typically malignant, although rarely they can be benign or borderline. Interestingly, 15 to 30% of these women who have endometrioid ovarian tumors will have concomitant endometrioid tumors. And similar to the endometrial cancer, endometrioid carcinoma have mutations in the PTEN suppressor gene. The fourth subclass is Brenner tumor. These are uncommon. They're mostly benign and solid. The epithelium that constitutes these tumors is similar to the transitional epithelium that lines the urinary tract, like the ureter or the urinary bladder. Occasionally, the nests are cystic and are lined by columnar mucus-secreting cells. Typically, they're smoothly encapsulated, and they arise from the surface epithelium or from the urogenital epithelium trapped within the germinal bridge. Again, they're mostly benign. The second major class of ovarian tumors is teratoma, and they stem from the germ cells. So teratoma is a neoplasm of germ cell origin, typically affecting young girls in the first 2 decades of life. The younger the female is, the more likely it's malignant. However, more than 90% of these germ cell tumors are benign. Specifically, they're mature cystic teratomas. The immature or malignant variants are rare. The mature cystic teratoma is, as we mentioned, benign. It's composed of several tissue types originating from the 3 embryonal cell types, if you remember, the endoderm, mesoderm, and ectoderm. And this tumor will show 3 subtypes of mature tissue stemming from these embryonal tissues. For example, you can see skin, sebaceous glands coming from, or neuronal tissue coming from the ectoderm. You can see muscle or adipose tissue coming from the mesoderm, and you can see respiratory or GI epithelium coming from the endoderm. 1% of them are malignant, and they can rarely transform into squamous cell carcinoma. This is an image of mature cystic teratoma. Notice the hair ball in the middle because, again, this tumor can form ectodermal tissue such as skin and hair follicles. A lot of times you can see bone and teeth, but again, this is all benign. The mature malignant teratomas, they are typically found early in age, early in life at the mean age of 18. They are different from benign teratomas because they're typically large, solid, they have areas of necrosis, and most importantly is seeing areas of immature differentiation, specifically neuroepithelial differentiation. Similar to the neuroepithelial tissue seen in embryos, it's immature and denotes aggressive and malignant behavior. There is a specific type of teratoma in which only one tissue type is seen, and the classic example is the struma ovarii, which is a type of ovarian teratoma composed exclusively of thyroid tissue. This thyroid tissue can secrete thyroxine and result in hyperthyroidism. Sometimes struma ovarii can be associated with carcinoid tumor, which is a low-grade malignant tumor composed of small cells that express neuroendocrine markers. This is an image showing 2 or 3 actually pathologies. At the left side with the blue arrow, you can see thyroid tissue representing struma ovarii. At the right side with the green arrow, this is cartilage. Again, mature tissue coming from the mesoderm. And in the middle, the red arrow pointing at adipose tissue, which is again derived from the mesoderm. These are just representative images, macroscopic and microscopic, of ovarian tumors. The serous tumors are typically smooth in contour, especially if they're benign. Mucinous ovarian tumors can attain huge sizes. Brenner tumors have epithelium that's similar to the urothelium or the transitional epithelium lining the urinary tract. This is another picture of mature cystic teratoma with the hair ball and the adipose tissue. And the right lower one is immature malignant teratoma with large size and invasion into the adjacent organs. Thank you so much. We will not be discussing the third subtype of ovarian tumors, the 6-cord stromal tumors. These are rare and beyond the scope of your studies. Please do not hesitate to ask if you have any questions. Always go back to Robin's 10th edition as your reference for this material. Please stay safe and stay healthy. Talk to you later.